So in this class, we'll be discussing about the ventilator management of COPD and asthma and the basic concepts related to it, and also humidification in the ICU. That will be the next topic. Okay. So whomever is present, even the 3 students are present. Just I want you to interact with me whenever I'm trying to explain a concept. If you don't understand, we can come back to it and we can redo it. That's not at all an issue. Okay. So what is an obstructive lung disease? Why ventilator management and obstructive lung disease is important? Before going on to the topic proper, we should know what are the conditions and how it is different from each other, so that we can adjust the ventilator setting as per the requirement. Okay. So COPD, the term consists of various disease conditions where it is actually a permanent destruction of the alveoli or the airway, and there will be a loss of elastic tissue. And whenever there is a trigger or an infection or an inflammation, there is going to be an associated mucosal edema, inflammation at the alveoli airway level, which is going to further worsen the anatomically distracted airways. Okay. But bronchial asthma, on the other hand, where the airways are normal, there is no baseline anatomic or genetic problems with the airway or the alveoli. But whenever there is an infection or an inflammation happens, the mucosa is going to become hyperemic edematous, causing flow limitation and airway obstruction. So this is a table describing the differences between the two conditions. So what is asthma? It is a chronic airway inflammation that causes respiratory symptoms that vary over time and an intensity with variable airflow limitation. But what is COPD? Again, it is a chronic respiratory disease where the symptoms occur due to the airway or the alveolar abnormalities. These are permanent abnormalities. Whatever we do, you give nebulization, you give steroids, you give antibiotics, these permanent anatomical abnormalities are not going to go away. That is the the bigger challenge in COPD is that the anatomical abnormalities cannot be wiped off. So you have to address the ventilator setting or even the NIV setting as per that required airway, but not like in asthma. Okay. So there is going to be chronic respiratory symptom due to airway or alveolar abnormalities, which cause persistent progressive airflow obstruction. Okay. The symptoms in both the situations are going to be more or less the same. Like patient can have dyspnea, wheezing, chest tightness, cough, activity limitation, because whenever a trigger happens, all these symptoms usually worsen. So more or less the symptomatology is going to be the same. That is why in undiagnosed patients with asthma or COPD, we usually suspect an overlap, because unless a CT is done, we won't be able to know it. Then coming on to the pathophysiology of asthma, it is an Ig mediated response that causes the mast cells to degranulate and release histamine, prostaglandins, leukotrienes, which could cause smooth muscle contraction and airway tightening. But in COPD, because of genetic factors, because of oxidative stress due to environmental factors, there is an inflammatory response which leads to the tissue destruction and structural changes that could cause progressive airflow limitation, ultimately leading to impaired gas exchange in the airways, in the lung parenchyma, and also there could be, because of the back pressure and the pressure changes in the airway and the alveoli, there could be problems with the pulmonary vasculature also. Okay. And how do you differentiate an asthma and a COPD? There are some bedside clinical clues where you can use a spirometry. For example, the patient is having a bronchospasm, you do a spirometry, you will get a graph. But after a bronchodilator therapy, you can see that the spirometry will show reversibility, meaning the baseline normal stage will return. But in COPD, even during bronchospasm, with or without nebulizers, with or without bronchospasm, it is going to show the same obstructive pattern in the spirometry. And in asthma, unless the patient is having an acute infection or an inflammation, they won't usually produce a lot of sputum. But in COPD, the patients can have in day-to-day of their life because of ineffective clearance, because the genetic reasons which I'm talking to you about is like the cilia problems or alpha-1 antitrypsin problems, which are all involved in the cilia motility, where the patient can have collected secretions which can come out as sputum every single day. They keep coughing, they keep producing sputum every single day. Okay, so that could be one of the differences. So basically, an asthma is a reversible situation, though it has expiratory flow limitation. It could be reversible with treatment, and the ventilator management we'll discuss. But COPD, because there is permanent damage to the alveoli, airway, etc., the symptoms are going to be persistent, and even the management is going to be a bit challenging compared to asthma. Okay. So, when you should be cautious in a COPD asthma patient, when you should be cautious that the airway protection may be required, anticipating they could deteriorate. If the patient had previous history of endotracheal intubations during exacerbations, if the patient had previous intensive care unit admissions in the previous exacerbations, or more than or equal to 2 non-ICU hospitalizations in the past 1 year, or more than or equal to 3 ED visits in the past month, or the patient is on chronic use of oral corticosteroids, which could cause immunosuppression and secondary infections, especially the fungal ones, and patient is having medication non-compliance, they do not follow the protocol properly, or the patient is not having any access to the health care, or the patient is already using more than or 2 short-acting bronchodilators to even control their symptoms, even for a maintenance of their symptoms, they are using more than or equal to 2 inhalers. In such situations, you should be ready for airway protection and supporting them through ventilator. So let us see in individual conditions, what are the changes that is going to happen with the respiratory mechanics in a patient. Okay. For example, now first let us take in COPD. Okay. You can see that in this chart, this is the inspiratory phase in COPD. So during inspiration, because of the negative intrathoracic pressure, or when you are giving a positive pressure ventilation through the ventilator, the airway is going to open up, right? Even though there is going to be a narrowing due to chronic inflammation because of the presence of mucus, and there might be a lot of remodeling, the inspiratory phase remains relatively preserved due to their distension, because it is like air flowing in. You are giving a positive pressure, the air can easily flow through, or in general, only in COPD patients, there is not much of an inspiratory limitation as much as seen in expiratory phase. Okay. So overall, the inspiratory phase in COPD is a less problematic phase in COPD, even the patient is spontaneously breathing or the patient is on positive pressure ventilation. Okay. But this is the expiratory phase of the COPD patients. So normally during expiration, there is going to be an increase in the intrathoracic pressure, which could like compress the intrathoracic airway normally in any patient. Okay. But in COPD, the airways are fragile because there is no elastic tissue, there is no elastic recoiling. Normally during expiration, the cartilage, the elastic recoiling, the patency of the airway will maintain the airway, preventing them from collapse so that expiration happens. Right. But in COPD, because the anatomical structures are lost because of chronic inflammation, genetic defect, environmental defect, the airways are going to normally collapse and create a choke point compared to a normal person. Right. And in general, in a spontaneously breathing patient during expiration, there is going to be an increase in the intrathoracic pressure, which normally exerts some effect on the airways. And in COPD patient, this effect is going to be exaggerated, and it is just going to just choke, and it is just going to create a collapse of these airways, where there is going to be an expiratory flow limitation. Okay. So in inspiratory phase in COPD, this limitation is not much seen because of the pressure we are giving through ventilator, or in a normally there is some negative intrathoracic pressure, the air falls into the lung because of this ambient to the alveolar pressure gradients. But in expiration, you have to passively exhale, you have to actively exhale against the intrathoracic pressure, and at the same time, because of these choke points, because of the anatomical abnormalities, because of the chronic inflammations, there are going to be various choke points at the small airway level, where these choke points are going to collapse the airways during expiration, and there is going to be expiratory flow limitation. Is there any doubt with this concept? If you have, please raise your hand. We'll go again. Because this concept is important when you are going to discuss about the waterfall phenomenon or the ventilatory management of COPD. Is that okay? Can we proceed to the next slide?
Yes, ma'am.
Yes, great. So, the same concept again explained at the alveolar level, but considering the flow pattern. Okay, normally, when there is an unobstructed flow, okay, during expiration, the expiratory flow follows an oscillatory flow pattern, where effectively from the lower airway to the upper airway, the flow is going to be transmitted and the expiration is going to be easy. But because of this choke points created in the COPD, the downward pressure is going, I mean, the alveolar pressure is going to be high because of dynamic hyperinflation or auto PEEP, and the expiratory flow is going to get limited and it is not going to follow an oscillatory flow. Okay. So, what happens in the COPD? Because there are multiple choke points, right? The airway is going to collapse during expiration. So, the alveoli, which has inspired some amount of air, is unable to vent out that air through the expiration, through the airway, because the airway is getting collapsed. So the alveoli is going to grow bigger and bigger with each inspiration because of this anatomical abnormalities. This process of incomplete expiration because of the choke points leading to progressive air trapping in the alveoli, where there is going to be an increased functional residual capacity above the normal relaxation volume, is called dynamic hyperinflation. So this is the process, this is the cause. When this dynamic hyperinflation happens, there is going to be a positive end expiratory pressure at the alveolar level, where which will be even higher than the normal end expiratory pressure. This positive end expiratory pressure that develops unintentionally due to the incomplete expiration and air trapping because of the dynamic hyperinflation is called auto PEEP. Basically, both are same, where dynamic hyperinflation is the terminology which is defining the cause of the auto PEEP, where auto PEEP is the effect of the dynamic hyperinflation. Okay, so airway is not emptying, the alveoli is not emptying the air because of the choke points. It is ultimately leading to a bigger alveoli called dynamic hyperinflation. And because of this swelling alveoli, there is a pressure getting created inside, which is above the normal end expiratory pressure. That is called auto PEEP. So hyperinflation is the cause and auto PEEP is the effect. Okay. So it is the same flow chart where patients with airway airflow limitation, the lung emptying is going to be slowed and expiration is interrupted by the next inspiratory effort, because you're trying to expire, that process is not happening. So by the time the expiratory time cessates and the next inspiration begins, and again you are going to take in air and you are unable to expire, so it is going to collect the air in the alveoli continuously. So the patient is not going to completely exhale the air, ultimately resulting in dynamic hyperinflation with increased functional residual capacity, and this will lead to auto PEEP. So what happens now? Normally during inspiration, what happens? Can anyone tell me, like, how does the air from the ambience enter into the lung? What are the pressure changes that we are going to see during normal inspiration? So what is going to be the ambient pressure? In order to initiate the inspiration, the ambient pressure should be more or less? Okay, so in order to initiate a normal inspiration, the alveolar pressure should be too low, the ambient pressure should be too high. That is when the flow of air happens from the outside to the inside. At the same time, in order to expire, the alveolar pressure should be high and the ambient pressure should be low. That is when the expiration process happens. But in a COPD, when the alveolar pressure is too high and with the second inspiratory cycle, the ambient pressure is also trying to be high, there is going to be a pressure fight where the patient has to take in a much negative pleural pressure to overcome the inside alveolar pressure, to overcome the ambient pressure, to allow the air inside the airway. So that is why the work of breathing is going to get increased when the autopeep is there. The patient has to fight the autopeep, the patient has to fight the pleural pressure so that the ambient airflow enters into the lung, because already the alveolar pressure is too high. If you keep the ambient pressure also high, then they can't inspire the next breath. There is going to be a like what to say, a pressure inequalization where patient can't trigger the next breath or take the next breath. That is why they have to put in a more negative pleural pressure, compensating the auto peep also. So there is going to be an increased work of breathing. Initially they can do that, but later they usually, the COPD patients will have a chronic inflammation, a poor malnourished state, their muscle capacity we don't know, so they usually end up getting fatigued and they start developing increased CO2 because of the autopeep also, because of the muscle fatigue also, which is going to complicate the situation. And when the autopeep develops in a patient who are sedated, paralyzed on a mechanical ventilator, the dynamic hyperinflation is going to increase the delivered mechanical power. There is going to be a risk of barotrauma, and this in turn will act on the heart-lung interaction and can worsen the hemodynamics, as we discussed in the previous class. If suppose the patient is triggering the ventilator, he has to put in a lot of effort to even trigger the next inspiratory cycle, right? So this is with respect to COPD. What happens in bronchial asthma? We discussed that in bronchial asthma, there is not much of an anatomical problem. So what is really happening with the asthma exacerbation? There is increase in the airway resistance. It is mainly due to bronchospasm, airway inflammation, and the mucus formation during a trigger phase. So this all will obstruct the expiratory flow, causing dynamic hyperinflation, alveolar overdistension, and some amount of autopeep if it is severe, if the bronchospasm is severe enough to cause such a bad dynamic hyperinflation, then eventually ending up in dead space ventilation and hypercapnia. That is how bronchial asthma patients develop a partial dynamic hyperinflation and autopeep when there is a severe bronchospasm, mucosal edema, and increased mucus production. Now, when we discuss about dynamic hyperinflation, there are three different types of dynamic hyperinflation. First one, we saw dynamic hyperinflation with the intrinsic expiratory flow limitation. That is as in COPD patients. Obviously, the anatomic destruction is there. So they are going to have expiratory flow limitation with an intrinsic problem. The primary example for such a situation is COPD. Okay. But dynamic hyperinflation can happen without intrinsic expiratory flow limitation also. So you have to be careful, not only in COPD patients or in other patients who have the following conditions. The dynamic hyperinflation could develop when they hemodynamically crash or when they have a sudden cardiac arrest with a pulseless electrical activity. You should have these causes could be back of the mind. Yeah, this patient could have had a dynamic hyperinflation. You should check the intrinsic PEEP. You should intervene accordingly. So in such situations, without intrinsic expiratory flow limitation, like rapid breaths, the patient is having, you have kept the patient's respiratory rate is around 42, 52. You have kept the respiratory rate around 34 for some other reason, like washing out CO2, or you want to handle an ARDS ventilation to maintain a pH. So you have to see that whether excessive rapid breaths is preventing the expiration, and you are keeping a high tidal volume, like you are damaging the lung by means of volume trauma because of a villi. You have to look whether you are giving a very high tidal volume according to the predicted body weight, or you have accidentally kept the IE ratio more, or for any such reasons. Usually we don't, but this is one of the cause when the inspiration is greater than the expiration, or there is an end expiratory pause because of a valvular problem, or there is a mechanical ventilator issue or the circuit issue. Because of all these reasons, mechanical and the ventilatory reasons, the patient can end up in dynamic hyperinflation without any intrinsic expiratory flow limitation. And not only that, when the patient is on a smaller endotracheal tube compared to his body weight and the sex, gender, and the appropriate size of the endotracheal tube, and if the tubing and devices have a blockage, the HME has a blockage, and there is some issue with the circuit itself, can all cause without dynamic hyperinflation without intrinsic expiratory flow limitation. And the patient can have dynamic hyperinflation because of excessive expiratory activity also. Like when the patient, like the rapid breaths only, it is the same explanation. When the patient is expiring very fast, okay, the alveoli is going to collapse, and there is going to be the collapsing pressure is going to be very high. Okay, actually the alveoli does not have any hyperinflation or an auto peep, but the alveolar pressure is too high because of rapid expiration, and because of the increased alveolar pressure, with the repeated pressure, the changes could happen. So this is what we explained. Dynamic hyperinflation with intrinsic expiratory flow limitation can happen with COPD, where because of the anatomical destruction, there is going to be limitation of the expiratory flow. There is autopy and DH. And without intrinsic expiratory limitation, we already discussed, if the respiratory rate is kept at more than 30, if there is prolonged inspiratory time, if there is increased tidal volume, all of this could cause dynamic hyperinflation without any intrinsic obstruction. So this is what I was discussing about exaggerated expiratory activity without any dynamic hyperinflation. That is, you are going to develop an auto peep. That is only the increased pressure, but there is not going to be any dynamic hyperinflation. So the increased pressure happens because the dynamic airway collapse with exaggerated expiratory activity. So the expiratory muscles are strong, and you are just trying to ventilate, or you are trying to compensate for the acute situation where there is increased expiratory activity. The muscles as well as the alveoli is going to collapse with increased pressure. But there is no air collection in the alveoli. Only the alveolar pressure is increasing for the increased expiratory activity. So there is going to be an auto peep, but without dynamic hyperinflation. You can't see this auto peep by end expiratory pause in the ventilator. This is just a clinical scenario. If you feel that the patient expiratory activity is too high, then you can just sedate, paralyze the patient, because this could also aggravate the auto peep and can cause a worsening of the auto peep by air collection in the next breaths. Okay. So what are the major adverse effects of the dynamic hyperinflation? We saw that because of this alveoli getting swollen up, being with every breath, the patient has to put in a lot of work even to trigger the next inspiration, right? So there is going to be an increase in the resistive and the elastic work of breathing, because of which the patient needs sedation and the prolonged ventilation, and weaning could be a more problematic process in COPD patients. It can even precipitate patient ventilator asynchrony. And at the same time, the alveoli is going to have a dead space. So there is going to be a dead space ventilation with a worsening of the gas exchange also. And when it comes to the other systems apart from the respiratory system, so we saw that whenever there is a positive pressure ventilation to the thorax, all the organs which is there in the thorax, like the lung, the heart, all of it are going to get affected, right? So especially in a patient who's having an auto peep, which itself is an increased intrathoracic pressure, and on the top of that you are giving a positive pressure ventilation, for example on a ventilated patient, what is going to happen? There is going to be even increase in the intrathoracic pressure. The venous return to the right side of the heart is going to go down, and the right side of the heart can develop increased pulmonary vascular resistance because of this collapse of the intra-alveolar vessels. And at the same time, the LV also may not receive much of a preload. Overall, there is going to be decrease in the right-sided preload, decrease in the left-sided preload, and increase in the right-sided afterload, which is going to worsen a lot of hemodynamics, where patient may not even have an adequate preload for the perfusion. Okay. Suppose if the patient is on a mechanical ventilator and having an auto peep, or the patient is on NIV with a COPD background with auto peep, if they suddenly arrest, you have to and arrest with a pulseless electrical activity, you have to keep this dynamic hyperinflation and auto peep in your differentials, so that if you just disconnect the ventilator for some time, the CO2 is going to wash out, the auto peep is going to reduce, which may bring back the hemodynamics to the normal, if that is the cause for the pulseless electrical activity. So we saw the types of dynamic hyperinflation. Let us discuss about the type of auto peep, which is the effect of the dynamic hyperinflation. It is based on the measurement. Auto peep can be divided into static and dynamic auto peep. Static means you are just pressing the end expiratory pause for 3 to 5 seconds and you are getting the total peep. you are subtracting it from the applied PEEP and you get the static auto PEEP. This is like how we measure hemodynamics, like we discussed in the last week. It is a snapshot measurement of one single reading of the auto PEEP. Whereas dynamic auto PEEP is that you are going to record the airflow as well as the airway positive end expiration, but you have to have an esophageal monitor for this, where it will show us the esophageal pressure, which is just a reflection of the pleural pressure, and you will have the airway pressure through the endotracheal tube. So with the particular device, you can see the esophageal tracing, the airflow tracing, the auto PEEP tracing, and you're going to continuously monitor the auto PEEP. So this is called dynamic auto PEEP measurement. Okay. So it is the simultaneous recording of the airflow and the airway pressure at the end expiration. In a spontaneously breathing patient, auto PEEP is determined by simultaneously recording the esophageal pressure and the airflow tracings. It is measured at the end expiration as the negative deflection of the esophageal pressure to the point of zero flow. Usually, it is less than the static auto PEEP, because it reflects the end expiratory pressure of the lung units with short time constants, but and rapid expiration, while the units with long time constants are still emptying. So usually the dynamic pressure measurements will be less than the static measurements, because it just records the quickly emptying units rather than the long emptying units. Okay. So coming on to measuring the auto PEEP. Can anyone tell me how do we measure auto PEEP? You should be the experts, I guess, which we do daily in any COPD patient. How do we measure auto PEEP? Is there anything that we should keep in mind while measuring auto PEEP? Which mode of ventilation, how long it should be measured, and how do you calculate the auto PEEP? Of course, I discussed this with you before. Like, can anybody tell me? Okay, so auto PEEP, usually it is a measurement which is done in a passively ventilated patient. For example, not necessarily sedated, but a patient who is not fighting the ventilator, who is just breathing along with the ventilator in a controlled mode without much of asynchrony, or in a sedated patient who is calm and the control mode of ventilation is taking over. Usually in such situations, that is when we measure the auto PEEP, basically the intrinsic PEEP. So you're gonna use any mode of ventilation, volume control or pressure control. But usually in COPD patients, we prefer volume control because the airway itself is having a lot of resistance. So whenever there is airflow limitation and changes in the resistance, the volume that is going to come in, the volume that is going to go out in a pressure control ventilation, it is not under our control. So there could be worsening of auto PEEP by means of hyperinflation, or there may be hypoventilation causing worsening of CO2, right? So in order to prevent such changes with respect to resistance, we prefer volume control more than the pressure control. So when you use a volume control, you have the control for the volume. So you fix a particular volume, you wash out the carbon dioxide as you want it to be, and then you can keep the ventilation at a particular volume throughout with even the resistance changes. That is why you prefer a constant flow of volume control ventilation rather than dynamically changing volume control with respect to pressure control ventilation. Okay. So first thing, you're going to measure the auto PEEP in a controlled mechanically ventilated patient. Most preferred mode is volume control mode. And you have to do an end expiratory pause maneuver for 3 to 5 seconds. You're going to get a value that is the total PEEP. So that total PEEP should be subtracted from the applied PEEP, which we would have kept in the ventilator, right? 5, 10 or whatever. So you have to subtract from the total PEEP, and the remaining is the intrinsic PEEP. There are some of the ventilators which shows the intrinsic PEEP alone, that are also there. So that is how you measure the auto PEEP. Okay. But where are you going to use this auto PEEP? In a control mechanically ventilated patients? No need. In a control mechanically ventilated patients, what is the method to overcome auto PEEP? Can anyone tell me? No, I don't want you to be interactive throughout, but at least I want to understand whether you are understanding what I'm speaking. That is what. Like, can anyone tell me, in a mechanically ventilated patient, how can we overcome auto PEEP? What can we do?
We can keep 80% of that. We can apply PEEP.
It is not in mechanically ventilated patients who are sedated. I'm asking about who are sedated, passively ventilated. sedated, controlled mode on ventilation, how can you overcome the auto PEEP? You can keep zero PEEP externally, and you can allow the resistance to the expiration to fall down so that the expiration happens easily. What you are telling is keeping the external PEEP more than 80% is in a spontaneously breathing patient who on a pressure support ventilation, or a patient is on CPAP ventilation or a pressure support ventilation, who are actively breathing with the ventilator to fight against the auto PEEP. In such cases, you can keep external PEEP higher. But in a passively ventilated patient, in a sedated patient, mechanically ventilated patients who are sedated, paralyzed, you can keep zero PEEP, which will reduce the expiratory resistance so that the expiration happens a bit more easily compared to a higher external PEEP. Okay, so that is why an auto PEEP is an ironically a controversial situation. I don't even know whether you are measuring something in a control mode and you are applying it in a patient who are spontaneously breathing, whether it is going to be fully reliable or not. I checked for evidences, but they have just all told it is a mechanism. Like you check in control mode, you apply it in spontaneous breathing. I could not find any evidence how it is sensibly applied in two different scenarios. Okay, if I find it, I'll share it in the group. So not to confuse anymore, so auto PEEP, how are we going to measure? In a mechanically ventilated patient who are passively breathing without fighting the ventilator, most probably in a volume control ventilation, most preferably, and you're going to do an end expiratory for pass for 3 to 5 seconds, and you're going to calculate the auto PEEP. Okay, so how are we going to recognize the auto PEEP with the ventilator graphs and all that? So you can see that in the flow time ventilator graph, even before the next inspiration is beginning, because of this, even before the first expiration is ending, the next inspiration begins. And you can see the auto PEEP getting developed. This is the normal flow time graph. But when auto PEEP is there, there is going to be an extension of the expiration auto PEEP. And even before the expiration is coming to the baseline, the new inspiratory waveform starts. So that is how you are going to pick up in flow time. And if you see in the flow volume, normally the flow volume curve should come to the baseline with expiration. But you can see there is an air trapping and the curve goes down. So this is one of the way how you are going to find out the auto PEEP. Okay. And what are the other methods you can find out? For example, you have disconnected the airway. You want to provide oxygen to the patient because there is auto PEEP. You are connecting a ambu bag. You can see that a slowly filling of the manual ventilator bag could indicate auto PEEP. The capnography trace is one of the good indicator, which is always connected to the monitor, where we can see it is not reaching the plateau. And the failure of the peak airway pressure to change when an external PEEP is applied is one of the indicator. See, if the patient already has an auto PEEP, that is air is trapped in the lung, when you apply an external PEEP, for example, you are just matching what is already there inside the alveoli. Okay, you are if you go high, it is going to worsen the dynamic hyperinflation. If you go low, the expiration is going to happen easily. But when you keep the same level, the pressures are going to match. If the intraalveolar pressure is 5 and you're keeping a PEEP of 5, it is just going to try and match. So there is not much of increase in the peak pressure. Normally, when you increase a PEEP in a patient without a COPD, you can see that the peak pressure increases. Sometimes plateau pressure also increases. But in an auto PEEP situation, this change in the peak pressure may not be so great, because you are just trying to equalize pressures in both directions, which may not impact on the peak pressures of the airway. Okay. In a paralyzed or a heavily sedated patient, there could be reduction of the plateau pressure after prolonged exhalation. So the prolonged exhalation will allow the trapped air inside the alveoli to escape, right? When you give this prolonged expiration maneuvers, you can see that the plateau pressure slowly dropping from its previous value, which could be a sign of auto PEEP getting resolved. So you can see the peak pressure, you can see the plateau pressure, you can see the capnographic value and the ventilator waveforms to recognize the auto PEEP. Okay. Is there any doubt till now? This finishes our concepts with the respiratory mechanics, but we'll be going on to the treatment part now. Do you have any doubt with the pathophysiology? Because this is important, like how, if you understand this only, we can apply the concepts in the treatment part. Do you want me to explain anything again? Okay, I'll take the silence as okay, and then we'll move on. Okay. So coming on to the goals of therapy. So our main goal of therapy is that we know there is an expiratory flow limitation. We have to somehow relieve the flow limitation so that the gas exchange, the hemodynamic compromise doesn't happen, right? How are we going to open the obstructed airways? Basic methods: bronchodilation. You can reduce the airway inflammation by means of corticosteroids. You can add the antibiotics if infection is the primary trigger for all such changes. And you can always maintain a bigger tube, do airway secretions, look for the circuits, valves in the ventilator, so that we don't complicate the situation. So this is how you're going to address the obstructed airways, so that the basic expiration happens without any limitation. Okay. And usually the COPD patients or chronic inflammation patients can have bullae, can have secondary fibrotic lung, can have previous remnant infection, which bacterial, viral, fungal, because of which various complications could happen. So in such cases, you have to look at the complication side also. If there is autopeep dynamic hyperinflation, you are going to adjust the ventilator setting. If there is a pneumothorax, you try to relieve that resistance so that the pleural pressure is coming down. And you also address the patient ventilator asynchrony by means of sedating, paralyzing the patient, and keeping the appropriate modes of ventilation. So first you clear out the obstructed airway, the basic steps. Then we are moving on to the ventilator part, which is going to prevent the secondary complications of the primary etiology. Okay. So, what are the ventilatory settings we are going to address in COPD or asthma? Considering asthma is also having bad dynamic hyperinflation because of the bad bronchospasm. So, as I already told you, it is better to choose a volume control mode where you have control of the carbon dioxide clearance, gas exchange, and where you could easily detect the air trapping in the flow time scalar or in the loops, flow volume loops. Yes, of course, we can detect it in any other loop too. But if you see, the flow time as well as the flow volume gives a better picture of it. And when you have a control over volume, the carbon dioxide clearance, which is a very important factor in COPD ventilation, and gas exchange to avoid dead space ventilation, will be in your control when you choose a volume control ventilation. If you choose a pressure control ventilation, because of a lot of resistance and changes in the airway, because of the underlying etiology, the volume coming in, going out may not be controlled by us. It just happens as per the resistance of the airway. So there could be hypoventilation, there could be hyperinflation. Either way, it can go. So that is why volume control mode is more preferred. When I looked for the evidences for this, there are few studies which say no mode is superior. It had some ARDS patients also, COPD patients also, no mode is superior. But there are some studies which say volume control is better than the pressure control. Okay. Second is FiO2. As we already know, you have to have a target of 88 to 92% in acute scenarios at least. You need not target a higher oxygen saturation. One, you are going to push the respiratory drive not to function. And number two, you are going to have an Haldane effect, which is going to worsen if you keep 100% oxygen. So better to maintain a saturation of 88 to 92% is the target for any COPD patient. But in asthma, you can even go up to 94 to 95. If suppose the patient is not having a bad type 2 failure, you can then definitely go up to 95, 96 also. Coming on to the rate. See, the rate, there is a myth that if the CO2 is high, you keep the increased respiratory rate. If the CO2 is high, you keep increased tidal volume. It is not like that. When it comes to a COPD ventilation, when you are doing something, for example, if you are increasing the respiratory rate, when you are increasing the tidal volume to improve the minute ventilation so that the CO2 will wash out, you should always have a parallel look of the flow volume graph, where we just saw that in flow volume graph, the auto peep is seen easily. But when you are changing the respiratory rate, or when you are increasing the tidal volume, you have to see whether compared to the previous graph trends, whether this expiratory curve is at least reaching close to the baseline. Okay, if that is not happening, when you're going to keep an increased respiratory rate, it is going to reduce the expiratory time, it is going to worsen the dynamic hyperinflation and auto PEEP. So it is not necessarily you should always keep an higher respiratory rate to wash out CO2. Actually, in COPD patient, if you keep an adequate appropriate tidal volume, even a low tidal volume, and number two, a moderate to low respiratory rate, and you keep increased expiratory time. If suppose the graph is coming back to the baseline, then you can keep an increased expiratory time. This would help the carbon dioxide to wash out better, rather than hyperventilating the patient, or you pump in more volume to dilate the alveoli more and more, creating more auto PEEP. That is not more sensible. This is more sensible. Keeping a moderate to low respiratory rate, keeping an adequate to a low tidal volume, and you increase the expiratory time a little bit more, then you will have a better washout of carbon dioxide, rather than just applying like a science concept. If I increase this, it's going to come down, because the COPD lung is not that way. If you're going to trigger it, it is going to worsen the auto PEEP, because the airways are constantly collapsing and opening. Okay. Coming on to the other parameters which you could do to adjust the carbon dioxide as well as the better COPD ventilation is that you can increase the inspiratory flow, like 60 liters per minute. Like in the presence of an incomplete exhalation, if you increase the inspiratory flow, it will just slightly reduce the inspiratory time, because you are achieving what you wanted to achieve in a particular inspiratory time of 1:2 whatsoever. You are giving a higher flow, inspiratory flow, which has been achieved even at the shorter time, where you will have more time for the expiration. So you give the target inspiratory flow, you reduce the inspiratory time, and then so that a time for exhalation increases. That is one of the method. And PEEP, as I told you, if the patient is completely sedated, ventilated, if you detect that the patient is having an auto PEEP, then better to keep ZEEP or zero PEEP, which will be helpful for that patient. But if the patient is spontaneously breathing on a pressure support CPAP ventilation, we have to keep match the external PEEP, which I will explain you in the next slides. You have to keep that in mind. Coming on to the trigger sensitivity, the flow trigger sensitivity, what to say, the value what they have told as per the evidences and the guidelines is that 2 liter per minute. Okay, if you keep the triggers sensitivity too low, like less than 2 liters per minute, it may cause auto triggering, where it can just detect the cardiac oscillations or some of the circuit leaks or nebulizers as false trigger breaths, and it can worsen the barotrauma and the dynamic hyperinflation. But if you keep too high, like more than 2 liters per minute, the patient has to generate a lot of pressure, lot of effort to start the next ventilation, next inspiration. So don't keep too low, less than 2 liter per minute, where the patient can have auto triggering and worsening of auto PEEP, or don't keep too high, where even the next breath becomes more difficult. Okay, try to keep it at 2 liters per minute. So coming on to the actual treatment of the auto PEEP, this is where what all concepts we discussed before is going to get applied. Okay. So how we can treat the auto PEEP? There are various methods. One is the ventilator settings. We already saw. You keep the respiratory rate moderate to low. You keep the tidal volume as per the body weight or a bit lower than the body weight. And then you increase the expiratory time. This is one of the sensible method to wash out the auto PEEP. Okay. And you reduce the ventilatory demand. If you can reduce the anxiety, pain, fever, shivering, and you reduce the dead space. Of course, HME is needed, but if the patient is having excessive auto PEEP, you can avoid at that particular situation a bigger tube without an HME, without the nebulizers for some time. You can just address the situation by reducing the dead space. And you can sedate, paralyze the patient, where the ventilatory demand of the patient will come down. And you have to reduce the resistance, because already intrinsically the airways are having a lot of resistance because of the edema and the inflammation. So you have to reduce the flow resistance by means of large tube, suctioning, and bronchodilators. Bronchodilators play a very important role. Okay. And the last method is that You have to balance the intrinsic PEEP by applying the extrinsic PEEP in a patient whom we are trying to wean off, or whom they are spontaneously breathing in a support ventilation. Even they are finding it difficult to trigger the next ventilation because of the auto PEEP. Then you have to adjust the external PEEP. Okay. That concept I have already explained you. See, I'm extremely sorry for my pictorial skills. I don't even have it. I just tried to do it just before the class. Okay, so this is the normal alveoli. Just imagine this. So this is a normal alveoli, and this is the normal airway. Okay, so each alveoli with an airway or the bronchiole will have a pressure called closing pressure, critical closing pressure. Okay, this is the pressure which is needed to keep the airway patent without any collapse during expiration. Okay. So in a normal alveoli, the critical closing pressure is very important and it is low, where expiration happens because the alveolar pressure is more than the ambient pressure, and it just goes out just normally without any trouble in an oscillating flow. It just washes out. Okay. And at the same way, the inspiration also happens because the ambient pressure is more than the alveolar pressure. So this is how inspiration happens without any obstruction. This is how expiration happens without any obstruction. And this critical closing pressure is very important because it prevents the airway from getting collapsed during the respiratory cycles, so that inspiration and expiration happens without any problem, especially the expiration. Okay, understood? That is understood. Now, coming on to the COPD patient. We saw that COPD patients will have an anatomical destruction or a genetic abnormality or some abnormality, because of which there are choke points in the airways, right? So, the alveoli is very big because of the auto PEEP. This is the critical closing pressure, which is very high, meaning the airway is trying to keep the airway patent. The pressure is trying to keep the airway patent, but the anatomy is not cooperating. There is no elastic tissue because of some genetic reasons. The structural integrity is gone. So the airway is trying to open up the pressure, but it is just collapsing because of the choking points. So the critical collapsing pressure is too high, and the choking points play an important role in this high pressure where the airway just collapse. Okay. I want you to just picturize this. The alveoli with an auto PEEP, a bigger auto PEEP, is the upstream part of the waterfall. Okay. The airway with the choking point, where there is increased critical closing pressure and there is choking point, the airway is just collapsing. Okay, like a waterfall, it is just collapsing because of the increased critical closing pressure. Even though it is trying to open up, the choke points are just compressing it and collapsing the airway. This is the waterfall. And downstream is the ventilator setting, external PEEP setting, which we have connected. So the COPD lung, okay, with a choke point and increased critical closing pressure, is usually compared to a waterfall called Pride's waterfall concept, where they just try to explain how a COPD lung looks. Okay, the upstream part of the waterfall is the alveoli with auto PEEP. So normally what happens, can just please interact with me, one of you. I would be happy just to make you understand, and I will be happy if you understand it. Okay, so I just want you to ask, in a waterfall, what happens when the upstream pressure is too high? What happens to the flow and what happens to the downstream pressure? Downstream pressure is nothing but the river which is getting the waterfall flow. So what happens? The upstream pressure is too high, and suddenly you are pushing that water through the waterfall and it comes and falls on the downstream. What happens to the what to say, the rate of fall of the waterfall? What happens to it? Like, can someone tell me? In a normal waterfall, I'm asking.
If the pressure is high, there will be turbulence created down.
Yeah, exactly. Super. May I know who's talking? Sorry, I didn't know who was talking.
Ma'am, Poonam.
Poonam, great Poonam. So, of course, whenever the upstream pressure is too high, ideally the waterfall has to pour in a lot of water, and the rate at which the waterfall falls from the cliff to the base will be faster. But there may not be much change in the downstream pressure because it is flat, it is accommodating. So, it will accommodate whatever speed the water is falling because the waterfall cliff is open. Right. But in a COPD, that doesn't happen. The waterfall upstream pressure is too high, but the edge pressure, the critical closing pressure, or the cliff pressure is compressed because of the choking points. Okay. So after that choking point, the airway is going to collapse because of its lack of elastic tissue, because it's an expiration, negative suction. It is just going to collapse because of the lack of anatomical integrity. So it just collapses like a waterfall with an obstructed cliff, and that is why it is called a waterfall phenomenon. So it depends on the upper pressure, which is above the upstream pressure, which is the alveolar pressure, is not in contact with the downstream pressure because of the choke point and the critical closing pressure, which is quite too high in a COPD patient. And that is why this particular concept is called waterfall phenomenon. After the choke point, the airways are just going to collapse like a tight waterfall, which is obstructed at the edge of the cliff, and the airways are just going to collapse, and the pressure is just going to drop like a waterfall. But the critical closing pressure is very high, but the airway is going to collapse like a waterfall, and that is why it is called a waterfall theory. Okay. Now let us just apply the concept. Now you are slowly increasing the downstream pressure. Okay, so before that, Poonam, can you only tell me, when this happens, when the sudden collapse happens, choke points happen, the airways collapse, how it is going to affect the patient? What sort of outcomes you're going to get in a patient when they have such a phenomenon in their airway? What is the outcome of it? They have to create in a lot of pleural negative pressure to overcome
Work
the
of
intrinsic.
breathing will increase.
Yeah, so the work of breathing will increase and their inspiratory effort will increase, which will again can cause patient ventilator dysynchrony, can worsen the barotrauma, volutrauma, and even worsen the dynamic hyperinflation and the autopeep, right? So this we don't want. You are measuring the autopeep in a controlled ventilated patient. You are trying to apply in that patient who's spontaneously breathing, who's trying to reduce their inspiratory effort because they are already struggling with the autopeep. So our goal should be how to reduce the excessive inspiratory effort or excessive respiratory effort of the patient. And that the answer to that question is external PEEP. So you should understand that external PEEP is not something which is going to completely resolve the auto PEEP. It is just going to take out the air from the alveoli to the out of. No, it's not like that. So extrinsic PEEP is just applied so that the patient does not struggle to initiate the next breath. Okay. If you have an alveolar pressure of 10, if you keep an extrinsic pressure of 7, along with the pleural pressure, you are only going to struggle for like 3 extra pressure to take the next breath, right? But if you keep the external PEEP as, like, for example, 1, and intrinsic PEEP is 10, you have to struggle for 9 pressure to initiate the next breath, right? So when you keep the extrinsic PEEP or the ambient PEEP a little bit more, the patient can overcome this ambient PEEP even better compared to the lower PEEP, so that the effort of breathing improves. That is why we keep external PEEP. So external PEEP is not like a complete solution for the auto PEEP. It is just going to help the patient to match the pressures and breathe adequately, so that eventually the pressure equalizes and the auto PEEP comes down. That is the ideology here. Okay. So what is the Pride's waterfall theory says? So when you raise the external PEEP from downstream the waterfall, okay, when you're slowly raising the water level downstream the waterfall to up, okay, close to the auto PEEP level, for example, 75 to 85% of the auto PEEP level, what happens is the patient will take only less effort to overcome the ambient PEEP, so that the inspiratory effort improves. Okay. But when you keep it too low or too high, it is not going to be beneficial. Too low, then no use at all. The patient is already in the same state. You are not going to change anything with the inspiratory effort. They are going to fight. Okay. And when you keep it too high, for example, auto PEEP is 10, you're going to keep it at 11. Okay. What is going to happen? The critical closing point of the airway is going to open up, and it is going to worsen the dynamic hyperinflation. It is going to worsen the auto PEEP. Then there is no use of keeping the external PEEP only. So that is why when you bring the downstream water up close to the auto PEEP level, it should be at least 75 to 85% of the auto PEEP, but not more than that. I mean, at least not above the auto PEEP value, or not too low compared to the auto PEEP value. Okay, is the concept clear, guys? You want me to explain again? I'm happy to. Is it okay? Guys, some response? Okay, so increasing the pressure downstream from the site of the small airway closure or collapse should not decrease the expiratory flow until the downstream water, that is the external PEEP, reaches the critical pressure. Okay, the external PEEP should be kept below 75 to 85% of the auto PEEP to avoid any worsening of hyperinflation or circulatory compromise. And in such cases, the dynamic pulmonary hyperinflation requires the insertion of the esophageal balloon and the assessment of the abdominal muscles that can be recruited during expiration. So what is that the dynamic auto PEEP measurements are better in such scenarios rather than static auto PEEP measurements. Okay. So this is what I just explained you. So auto PEEP is the pressure above the waterfall, that is the alveoli, where the critical closing pressure is the edge of the cliff of the waterfall, which is collapsed in the, which is high in the COPD patients because of the choke points, below which the airway just collapses because of the loss of anatomical integrity. And then the downstream is the external pressure which you are applying. Sorry. So when you keep the external PEEP at 0, whatever is happening here above the waterfall critical point remains the same. The airways remains collapsed, and the critical closing pressure is going to be high. So there is no use of keeping external PEEP when the external PEEP 0, when the patient is spontaneously breathing and trying to take the next effort. Okay. But when you keep the external PEEP close to the auto PEEP, you can see that it is matching up with the auto PEEP, where patient need not take an excessive effort to overcome the ambient PEEP, and so that the inspiratory effort becomes better. But when you keep the external PEEP more than the critical closing pressure, you're going to worsen the dynamic hyperinflation, because you're extensively extending the airway as well as the alveoli because of the PEEP. Okay. So if you see this table, I hope you will understand even better. See, the auto PEEP is approximately 8, and you're keeping the external PEEP as 0. And always you set a ventilator trigger sensitivity. You have to include that into the picture if you're keeping the trigger sensitivity. So the patient has to overcome 10 of the pressure to minus 10 of the pressure to initiate the next breath, right? Now, when you, if the intrinsic PEEP is 8 and trigger sensitivity is 2, when you keep the external PEEP is 6, you can see that the patient has to overcome a pressure of only 4 to initiate the next breath. But when you keep external PEEP more than the intrinsic PEEP, you are going to, I mean, this is close value, like same as the intrinsic PEEP, then you are, the patient effort may not change, but they will feel comfortable. But when you keep more than the intrinsic PEEP, the dynamic hyperinflation is going to worsen, and the patient will end up having hemodynamic compromise and even worsening auto PEEP. Okay. So the final single liner is, when you're taking, when you're setting an external PEEP for a spontaneously breathing patient on a ventilator in a COPD, when they're struggling hard to even trigger the next breath, keep the external PEEP 75 to 85% close to the auto PEEP, not more, not too less. Less, no value. More has dynamic hyperinflation. Okay. This could be asked as a short note, 5 mark. You have to explain the concept of the Pride's waterfall phenomenon. You have to explain this in detail, and you have to put in a chart. This chart is mandatory. Okay. And you have to put in an example table with whatever pressures you want. You have to make sure you let them know that you understood the concept. You are not just mugging up and writing, because recently all the professors who are correcting the answer papers, their outputs are like the concepts is understood or not, whether they are applying it clinically or not. We could see many people failing because of just 4-line writing, not finishing the answer papers. If you know the concept, if you could draw this diagram, if you put a table and you explain it with a waterfall concept, and external peep is not going to solve the situation, but it may help the patient have a less inspiratory effort, this is more than enough to score better. If you have any doubts at all, I understand it could be confusing. Please get back to me personally also. I don't mind explaining you again. Okay. So this completes the treatment of the auto peep. So you're going to reduce the resistance. You are going to keep external peep. You are going to keep the patient flow constant, and you're going to adjust the ventilator so that the auto peep and CO2 is washing out. Okay. Coming on to weaning from ventilator, so that is how you start with, right? The need for the external peep starts with when the patient is awake and they are trying to breathe on their own. You are putting them on a pressure support ventilation, so that is when you will try to match them up with the external peep, right? So you can start with the pressure support ventilation for weaning, and then it is better to wean COPD patients to NIV rather than a normal face mask or an high flow, because NIV has the same effects as in positive pressure ventilation. So you should wean the patient on NIV only. It will be better explained in an NIV class in the next lectures. In case of a spontaneously breathing patient who are presenting with type 2 respiratory failure with a pH of 7.2, then you try targeting the pH rather than the carbon dioxide. You keep the patient on NIV for the respiratory support, the muscle support, as well as the ventilation support. If suppose you're putting the patient on assist control ventilation, you try to put them on volume control initially and later taper them to pressure support ventilation, and then you wean them off to the NIV. Okay. This finishes our lecture in COPD. Let us go to the humidification class. Any doubts at all, please get back. Humidification is actually a small topic. It was never asked before in any of the papers before, I guess. But recently they are asking the practical aspects. Big things are gone now. Small things have been asked, like HME, ventilator circuit, physiotherapy, DVT prophylaxis. The small components are being asked as the questions. So I would want you to just know these flow charts better. You will score full if you read this material. This is enough. This is from the recent update. So humidification in the ICU. So humidification is nothing but a process of increasing the moisture content of the air. Okay. Whenever a patient is on mechanical ventilation, you are artificially subjecting the patient's airway to a dry environment. Okay. So this may cause respiratory epithelium damage due to the exposure to the dry gas, where there could be cytoplasmic damage, nuclear damage, ciliary damage. Okay. So when the mucosa is getting affected, when the cilia is getting affected, there is going to be decreased mucus clearance, and the patient is going to have increased resistance. They are going to have increased work of breathing to overcome this resistance. There could be atelectasis because of the mucus plug. There could be thick secretions which you may not be able to take it out with normal suctioning, and the patient can end up having severe cough or bronchospasm. Okay. Overall, all of this can lead to secondary ventilator associated pneumonia, delayed weaning, and increased mortality, which may eventually lead to poorer patient outcomes. Okay. So humidity is nothing but a moisture content. When you put the patient on mechanical ventilator, it is going to give a dry environment, which is going to damage the mucosa and cilia, which is going to cause dry, thick secretions, which has its own complications and eventually poor outcome. Okay. So before understanding what are the type of humidifiers, we'll just understand the basic definitions of humidity. I'll try to put it in simple words so that you can understand. But first, let us see the actual definition, and then we'll go to the simpler definition. Okay. So humidity, I think this you will understand. It is the amount of the water vapor present in the air. Okay. And the humidity can be absolute humidity and it can be relative humidity. Just know the definition for now. Absolute humidity is the weight of the water present in a given volume of gas. For example, 34 milligram per liter of water is present, 34 milligram of water is present in the 1 liter of gas. It is like that. Okay. And relative humidity is that it is the ratio of the actual weight of the water vapor, absolute relative to the absolute humidity, to the gas capacity to keep the water at the specific temperature. You didn't understand, right? Even I didn't understand. After that, I read through simpler terms. That's when I understood it. So, absolute humidity, relative humidity, we saw absolute humidity is defined as the weight of the water present in the given volume of gas. And relative humidity is the ratio of the actual weight of the water vapor related to the gas capacity to hold the water at the specific temperature. In simpler terms, you have a sponge. Okay. So, absolute humidity is that how much of the water the sponge can hold, or you can tell how much of water is present in the sponge. That is called absolute humidity. So, sponge is like a 1 liter of gas. When you call it as an absolute humidity, you are just checking how much of the water is present in the sponge. That is called absolute humidity. Okay, but when you define relative humidity, how full is the sponge compared to its capacity? Meaning, how much water vapor or the water a sponge could accommodate compared to its capacity. Okay, that is called relative relative humidity. Okay, for example, if the sponge can hold 40 ml and it's old 40 ml, then it is called 100% relative humidity. Okay, if suppose a sponge can hold 40 ml and it is only having 20 ml, then it is called 50% of relative humidity. Okay, you understood that? Can you give me an yes or no? So can anyone tell me in relation to sponge what is called an absolute humidity? Okay, so how much of the water is present in the sponge is called absolute humidity. And what is relative humidity? How full is the sponge compared to its capacity? Okay. So when you apply this concept in the airway, when you call absolute humidity with respect to airway, it is the actual water content available for airway humidification. That is called absolute humidity. Okay. So when you are selecting a device should have so and so of absolute humidity so that it can moisturize, it can humidify the airway. That is called absolute humidity. Okay, but what is relative humidity? It indicates the potential for consideration. For example, if an airway can hold 40 ml, you have to adjust the relative humidity at either 100% or little below that, right? You cannot adjust it beyond 100% because chances of water vapor getting condensed in the airway, causing auto triggering, causing resistance, causing blockage, all that could happen, right? So your relative humidity should be it should be 100% or little less than that, but that is accepted. But beyond 100% of relative humidity, if you keep filling the sponge beyond its capacity, it's 40 ml, you fill 40 ml. If you fill 20 ml, that is all right. But if you fill 60 ml, it is going to pour out some amount of water and the water vapor is going to condense into the airway circuit and it is going to cause some of the complications. That is called relative humidity. But so both of these values should be fulfilled when you select a device for humidifying a patient's airway so that thick secretions won't happen. Okay, I hope you understood. If you have doubts, as you're not responding, guys, I have to move on. So usually absolute humidity is measured as milligram per liter, and relative humidity, because it's a ratio and you're comparing how much volume it can accommodate and all that, so it is measured in percentage. Normally, absolute humidity is temperature independent. Okay, meaning you select a device with particular absolute humidity, it is going to humidify the circuit as per its value. It is going to humidify and work accordingly to the value. It is not temperature dependent. But relative humidity is temperature dependent. Why? Because the water vapor condenses differently at different temperature, right? So when the temperature is too low, there could be increased water vapor formation. When the temperature is too high, there could be decreased water vapor formation. So it is always temperature dependent. Relative humidity is always temperature dependent. Okay. And the clinical problem is that can occur with absolute humidity is that when you don't select a device with an appropriate absolute humidity, then there is no use of using that device only. It is same as a mechanical ventilator, which is keeping the dry airway. Okay. And when you use a device with an higher relative humidity, that is the clinical importance of relative humidity. When you use a device with a higher relative humidity, then it can again cause water condensation because of the water vapor getting condensed. Then it can unnecessarily form water in the circuit and worsen the resistance of the patient circuit. Okay. So these two values are very important when you are choosing an humidifying device. The absolute humidity is going to humidify the airway as per its value. A relative humidity is going to tell us whether the device is going to condense unnecessary fluid, or it is going to adequately maintain the water vapor according to its capacity of the circuit is the one. Okay. So when you, this is a table showing the absolute and the relative humidity of the airway tract starting from nose and mouth to the mid trachea and below the trachea. You can see that the absolute humidity of the nose and the mouth is around 10. And the relative humidity is around 50%. Okay. When it reaches the hypopharynx, the relative humidity increases. It is around 95%, and even the absolute humidity increases, meaning it needs more water to humidify the airway. And that particular portion is highly humidified, 28 to 34. Coming on to mid trachea, the relative humidity reaches 100% and the absolute humidity reaches 36 to 40%, where full saturation is achieved. But when you put the patient on mechanical ventilator, this may get disrupted, and the entire, starting from nose to till the trachea, may become more drier with a less absolute, with less relative. So the patient will end up having thick secretions. Okay. Now, what is the solution for this problem? We are going to add a device called humidifier with your specified values of absolute and relative humidity connected to a ventilator so that we can overcome the situation. So, humidifiers can be classified into active and passive. Okay. Active, common sense, where it uses an external resource to achieve humidification. Okay. It can be bubble, it can be passover, it can be inline, it can be counterflow vaporizers. Okay. So basically it uses an external resource to stimulate the humidification and deliver that amount of absolute and relative humidity to the circuit. What is passive? Passive means it uses patient's own resources. Okay. When the patient is exhaling, the patient will have some amount of temperature, water vapor when they are exhaling, right? It just traps it from the exhaled air. And when the inflow happens, it uses the same trapped humidity into the inflow air and delivers back to the patient. Okay. These are called passive humidifiers, where it uses the patient's own resources to humidify the circuit. These are called heat moist exchangers. And heat moist exchanges can be divided into hydrophobic, meaning which does not attract unnecessary water in the circuit, and hydrophobic and hygroscopic. This is one of the good HMEs, where it doesn't take unnecessary water, and it has some materials called hygroscopic materials or salts like calcium chloride, lithium chloride, for enhanced water vapor attraction capacity. So it maintains the humidity, but it does not attract unnecessary water alone. Okay. And then comes pure hygroscopic, where these salts will help in retaining the humidity from the exhaled air and putting it back into the inhaled air. Okay. So this is the picture of active humidifier. You can see that the ventilator gives a cold dry gas. So there is I hope all of you would have seen the heated humidifiers. There is a filler with the water, and it bubbles and it is connected to a intrinsic heat filament which regulates the temperature, and then it heats the air, and then it is passed back to the patient as a warm humid gas, And you have values for it, where the temperature is kept at 37 degree and the relative humidity should be 100% and absolute humidity should be 44 milligram per liter as per the different parts of the airway, especially to the mid trachea. All of that is being maintained and written back to the patient. Okay, so these values are very important because it should match with the normal airway of the patient, so that it won't dry up the secretions, nor it would condense and create any complications. Okay, this is with respect to active humidifiers. So passive humidifiers, I already told you, the expired air contains large amount of water vapor. So when it goes out, the hygroscopic hydrophobic material in the HMEs will trap the water vapor for the next breath. And then when the next inhaled air comes, the humidity is added to the inhaled air and then sent back to the patient. Okay, usually the ideal position to connect the humidifier is close to the patient as much as possible. And there are various connectors starting from 15, 22, 25 connectors based on the endotracheal tube size. You can connect ventilator circuits also, so you can connect as per the size based measurements. Okay, now how I am going to choose my patient needs an heated humidifier or an HME, how it is going to happen. So there is a tree, a decision tree, where you 100% know that when a patient is on mechanical ventilator, you have to put them on an humidifier, right? That much you know. Now, if the patient is requiring continuous humidification, then you can either choose active or passive. But if the patient is getting transported or to like CT or an MRI or to anywhere transported, then you can use passive humidifiers. But the best method is active humidifier, which gives the appropriate value levels, because there is an eating filament, there is a separate pot which is eating the bubble and then giving back to the patient. So active is more preferable for continuous and long stay patients. Okay, if it is a short ventilatory status and patient is getting shifted for anything, then HME is a better choice, passive is a better choice. But if the patient is on non-invasive ventilation, even with NIV we connect this, right? Sorry, if the patient is on non-invasive ventilation, if the duration is less than 96 hours, then you can use HME. If the patient is going to have a prolonged NIV support, then it is better to put an heated humidifier. Okay, so the decision tree is like, if the patient is going to have a continuous prolonged stay, use active humidifier. If it is a short term or a transport use, then you use passive humidifier. Again, same way, non-invasive ventilation, short term less than 96 hours, you use HME. If it is a long term, you use heated humidifier. Okay. What are the contraindications when you should not put the patient on HMV? These are not absolute ones. These are relative ones based on the clinical situation. If the patient is already having a frank, bloody, thick, copious secretion, then you try to avoid. When the patient is on low tidal volume ventilation, all the time we do put it just to avoid resistance. If it is causing any resistance issues, then you can remove it. If the expired tidal volume is less than 70% of the delivered tidal volume, in cases of uncuffed DET or a T fistula, then you try to avoid. If the patient is hypothermic, you are keeping the patient in hypothermia for some medical reason, or the patient is hypothermic, which could worsen the condensation in the circuit. So in such cases, you can avoid. And patient generating high minute volume can again condense more water vapor. That is the reason you can avoid. And it should be switched off during nebulization, because again condensation is the reason. And relatively cautious use in NIV, especially in the presence of leak, it can increase the dead space and can cause worsening of the type 2 failure. So these are not, as I said, these are not absolute contraindications, but you sensibly apply the decision tree and decide. Okay. Now, so as per the guidelines and evidences, how are we going to choose the HMEs? As per the guidelines, you have to choose preferably a hydrophobic, hygroscopic if you're choosing an HME. And if it is an heated one, it should have at least 33 to 44 milligram of absolute humidity and 100% relative humidity. Okay. And when we see the occlusion risk, as per the recent studies, the endotracheal tube occlusion risks were higher with the HMV. So when you see a patient with increased resistance or increased CO2 retention, increased dead space, try to avoid that. And in a patient with higher minute ventilation, more than 10 liters per minute, even hydrophobic HME had more occlusion compared to the heated humidifier. And when you are comparing in general hydroscopic HME with the heated humidifier plays a better role in humidification as well as in avoiding complications. So even as per guidelines, even as per evidences, heated humidifiers are more preferable. But you see, based on the patient's duration of stay and the need for the HMEs, okay? And when should we change the HME? Usually, it is safe to change every 48 hours instead of 24 hours. You can even continue up to 7 days if it is not soiled, but it is not suggested. So, it is better to change every 48 hours. And don't try to use HMEs in a patient who is hypothermic, that is below 32 degrees Celsius. And if the patient is having thick secretions and prolonged ventilation, avoid HMEs. Okay. So, as I said, short term, low secretion burden, go with hygroscopic. Long term, go with heated. Minute ventilation more than 10, heated. If there is thick copious secretion, heated. Hypothermia, heated. And in cost and resource limited settings, you can use HME. Okay. So, what are when it comes to humidifiers? So, adverse effects on ventilation, it can increase the dead space, it can increase the type 2 failure, eventually leading up to complications of this type 2 failure. And when you see this, why does such complications develop? Okay. And that we will see in the next slides. So the common complications which we see is related to thermal. One is when the patient is having hypothermia, there is excessive chances of condensation, which will worsen the situation. If there is hyperthermia, again, it is going to make the secretions even more thicker, because that is how the relative humidity is going to function inversely. And when the patient is having increased work of breathing, then increased dead space ventilation with the HME devices could happen. So try to avoid that. When the patient is having carbon dioxide retention, avoid HME. When the patient is having thick dry secretions, avoid HME. And when the patient is having excessive ventilator asynchrony, try to avoid humidifiers. And especially in NIV, helmet NIV, adding an humidifier could unnecessarily fog the helmet and may not help in the actual beneficial cause why we are using the helmet and NIV. And sometimes accidental burns could happen with respect to caregivers. So these are the complications of the humidification system. One is increasing the dead space ventilation. One, based on temperature, it could worsen the secretions thick, make it dry, or may condense water and cause complications. And it can cause patient ventilator asynchrony and accidental burns. But what are the risk factors for complications? Not we are putting humidifiers in all patients, right? Day to day, these complications do not happen. We don't remove HME, right? In which patients the complications are more common? The high risk patients are the patients who are dehydrated, okay, who are sick. So in such dehydrated patients, the secretions will be thick, the water content will already be low. When you add an HME with a lot of temperature variations, then that could worsen the situation. And in patients who require high minute ventilation, again the situation can worsen. And the moderate risk patients are prolonged ventilation. Like in prolonged ventilation, it is better to use heated humidifiers rather than HMEs, because HMEs do not function for such a long time as effectively as in heated humidifier. And elderly patients are at risk to develop such complications. And specifically, if the patient is having any previous lung disease like fibrotic lung disease or ciliary dysfunction, or in COPD patients, these patients are more prone for the complications. So elderly, dehydrated, COPD, increased minute ventilation, and underlying diseases. So these are all could be the risk factors in whom the complications of HME could be more significant. Okay. So how we can prevent the complications of the HME? Technically, you have to set the position of the HME proper, or the heated humidifier proper, and you have to check the absolute humidity and relative humidity as per the manufacturer's this thing. They would have given the details of how much absolute humidity it gives, how much temperature it maintains, how automatically it maintains things. So you have to look into that and set the temperature, AH, RH properly, and the position of the humidifiers properly. And you try to maintain hydration of the patient so that they don't go into the dry state. and you always select the high risk patients and always anticipate some risk is going to come, and try to put on the heated humidifiers more safely, and train the staff regularly, and always use safe methods without burning yourself, and regular monitoring for ventilator synchrony, secretion status, and dead space ventilation, so that it can be monitored. So it should be a multi-level support rather than a single HME related support. You have to see the patient factors also, you have to see the HME factors also, you have to see the trained staff's factors also. All that integrated will prevent the complications of HME. And coming on to the incidence of VAP with respect to HME, there are various data with respect to that. Actually, overall, as a gist with meta-analysis, there is no difference in the incidence of VAP whether you are using a heated humidifier or an HME. Okay. But heated humidifiers are more preferable than the HME when it comes to most of the clinical status, which can even reduce the thick secretions, which can even prevent VAP, but it is not like proven. Heated humidifiers prevent VAP. It is not proven by any evidence. Most of the evidences say both are equally, like the incidence of the VAP does not vary with whatever humidifiers you use, but heated humidifiers are more preferable because it acts with a better temperature control, better absolute humidity, and better relative humidity. Okay, so prefer more of an heated humidifier than the HME, but practically, if it is a shorter stay, HME, long stay, then heated humidifier. Okay. So this completes our humidification class. I don't think you have much of a doubt in this. It's a simple concept. Like when a question is asked, you have to write about what is humidity, absolute humidity, relative humidity. What does the evidence say? How much AH, RH you should use, and how you are dividing the humidifier, and what is the principle under which the humidifiers work, and then which is more preferable as per the evidence, and with respect to VAP incidence. This much you have to tell along with the complications. Okay, then only you will get the full mark. Okay, guys, thank you for listening. If there is any doubt at all, you can ask. If not, we can finish the class. You can stop recording, Bhageshri.